Okay, there we go. You probably would have no one over there except for the respiratory therapist that would know about this, but you might have this question on NCLEX. It is part of the NCLEX curriculum, so we want to make sure that you know how to do this. Now, the CO2 carbonic acid ratio is always a comparison number. It's comparison to see if your patient is improving or not improving. Are they breathing better, or is their situation getting better? So a 20-to-1 CO2 carbonic acid ratio is normal. That is considered in balance. The further away from 20-to-1 you get, the more out of balance you are. So you do the problem, and you have to know how to work the problem, and you compare two numbers. If your number gets further away from 20, then your patient's doing worse. If your numbers get closer to 20, your patient is improving. Now, less than 20, your patient is acidic. Just like 7.35 to 7.45, less than 7.35 is acidic, greater than 7.45 is alkalotic. The same thing with the 20-to-1 ratio. If your ratio is less than 20, you are acidic. If you're greater than 20, you're alkalotic. So less than 20 is acidic, greater than 20 is alkalotic. Right? So the way that you work this is you look at your ABG, and so I wrote a couple of them down here just to give you a couple examples. All right, so let's say your patient has a pH of 7.3. They have a PCO2 of 68, and they have a bicarb of 28. So you know that they're acidic. Their PCO2, which is their respiratory acid, is high. So you know that they are in respiratory acidosis. And their bicarb is high. So they are in partially compensated respiratory acidosis. That's what that ABG would be. Now, to figure out your CO2 carbonic acid ratio, you take your CO2 and you multiply it by 0.03. That is a constant. That never changes. So whatever their CO2 is, you multiply it by 0.03. So 68 times 0.03, and you should have got 2.04 for your answer. Now you take their bicarb, which is 28, and divide that by the number that you got when you took your CO2 and multiplied it by 0.03. So you take 28 and you divide it by 2.04, and you got 13.725. So that's what this first one is. Okay, so they're in respiratory acidosis. So I don't know, we put them on oxygen, and 30 minutes later we redraw a ABG. And I want to know if that oxygen helped them, or do we need to do more? Do we need to maybe intubate them? Are they getting better, or are they getting worse? So their pH now, 30 minutes later, is 7.31. Their PCO2 is 67. And their bicarb is 29. So I want to know, is their respiratory status improving? Or is it worsening? Or maybe it's the same. So I take the 67 and I multiply it by 0.03. And I get 2.01. And I divide that number into the bicarb, which is 29, and their number is 14.427. Did this person get closer to 20 or further away from 20? Because 20 is good. So somebody tell me, is 14.427 better than 13.725 or not?
Yes.
Yes. So putting them on oxygen made their acid-base balance better. Their respiratory status improved. It helped. And so that's what you're looking at. It actually helped their status. So let's look at another one. pH is 7.5. I'm going to let you all work it. 7.5. The PCO2 is 40. The bicarb is 34. Okay. They're very alkalotic. All right, they're metabolic alkalosis. So this person, had quite a problem with vomiting. They've been vomiting. Okay. So 30 minutes later, we check this person out, and their pH is 7.47. Their PCO2 is 38. And their bicarb is 33. Are they better or are they worse?
Worse.
What numbers did you get?
For the first one, I got 28.3 repeating. And for the second one, I got 28.947.
Okay, right. So they went further away from 20. Even though their pH was better, they really did, their metabolic acidosis was not improving. Even though their pH is better, their acid-base status was not improving. We need to do more than just sit and watch them. They're going to need some more treatment than that. Whether we need to stop what's causing their metabolic acidosis or something, their status is not improving. Even though when you kind of look at it, you may think they are improving, but their Kussmaul's are really getting worse because they're blowing off more CO2. So just looking at the numbers may not tell you that. You've got to do the comparison of the values. So on a test, yes, I would give you probably two values, and I would say, do you think they're better? Or are they improving? Are they worse? Or it could be that I ask you numbers. It could be, I don't know how it might be asked, but you would be asked to compare, and then are they better, are they worse, or give me whatever, however I might ask it. But in order to compare values and improvement or not, you've got to work the ratio. Okay. All right. Any questions on that? Okay. We're going to go on to burns. It'll take the full 2 hours to get to burns, so let's get moving on it. Probably, I've had a lot of jobs. I actually haven't worked a lot of units, but I've had a lot of jobs. The first job out of school was I worked on a floor that had 135 patient beds, big floor, huge floor. It was cardiothoracic, it was general surgery, it was vascular surgery, it was orthopedics and ophthalmology and plastics, and it had a 12-bed septic ICU and an 8-bed burn unit. That was what was on this floor. Then I became the nurse manager of this floor. And first I went to the ICU and I worked in their ICU. And then I worked in their burn unit. And then I became the nurse manager of this unit. And probably the worst job of my life for me personally was the burn unit. I actually worked the burn unit, but I despised it. It was not for me. And that's one thing about nursing. There's areas for everybody and there's areas not for everybody. But I was a burn unit nurse for a while, and I found that this was not an area that I particularly liked, but many, many people do. Now, when we're dealing with burns, it affects all organ systems. It's not just the skin that's involved. There's lots and lots. It's going to affect almost every organ in the body when the patient is burned. We typically will reach a plateau of affecting all of the organs in your body when you get at about a 60% body surface burn. After that, you may not have as much skin that you can use, but your internal organs are pretty much maxed out when you're at a 60%. When you're at a 60% burn, you will max out your internal organs. So it's a total thing. It's a total body. It's a total body type system. situation. Just some pathophysiology. There's about 450,000 burns each year in the United States. So we see it's pretty common. It's a very lethal form of trauma. The rehab stage is about 7 times as long as the hospitalization phase. So rehab is a long, long time as far as burns go. Burns can be caused by a lot of different causes. Thermal burns are typical heat. You can have chemical burns, you can have electrical burns, you can have radiation burns like from the McGuire nuclear plant. We are going to concentrate on thermal burns during this course. So just, it is the number one thing that we're going to deal with. By far, the most common age of burns are going to be the very young, and I hate this, older than 65, the very old. And most of that is due to cognitive levels, not making great decisions, not being as strong on your feet, maybe tripping and falling into fires or pulling over cords and things like that. But technically, or typically, it's because of cognitive levels that increase the more frequency of burns that we see. Now, when we're talking about burns, there's lots of ways of classifications of burns. And the ones that you're going to see on NCLEX are using the term superficial, partial thickness, and full thickness. You will not see first degree, second degree, and third degree burns. Now, people call them first degree, second degree, and third degree burns, but on NCLEX and in your book, they will use the term superficial, partial thickness, and full thickness burns. Now, superficial burns, and this is just a picture because I'm going to go off the slide fairly quickly. Superficial burns is this top one. It just affects the epidermis. It simply affects the top layer of the skin. It doesn't affect any of the deep tissues at all, but this is simply a superficial burn. A partial thickness burn is deeper. It affects both the hair follicles and the sweat glands and the dermis. So a partial thickness burn, you're looking at this layer. A full thickness burn is down into the fat tissue or the adipose tissue. It can be in the muscle. It can go all the way to the bone. This is also where your blood vessels are. So it's very deep, and it affects the deeper structures when we're talking about it. So this is where the superficial, partial thickness, and a full thickness burn is going to be. A full thickness burn is, again, just the top layer of the skin. The most common one you're used to seeing is a sunburn. There's very minimal damage. There are no blisters. It's very pink. It's very dry in nature. You push on it and it will turn white, and then as soon as you let it go, it will turn back to pink in color. It is very painful, and it lasts about 5 days, and then it will go away. The nerve endings are exposed, and it does hurt quite a bit. Yes, African American and dark-skinned people can get sunburned, and their skin does tend to have a pinkish to red cast underneath it. Typically, people that have sunburns and they say, I blistered, they typically did not blister. If it blistered, you will have blisters immediately. Typically, what happens is in about 2 to 3 days, the top layer starts to come off and it bubbles up. And they think those are blisters, and it starts to peel off, but those are not blisters. That is simply dead skin. Blisters will have water in them. So you might end up with something a little deeper on your nose that's but it will come up immediately, like the night of the first day of the burn. But superficial burns will not have blisters on them. So typically it's just pink in nature and very, very dry, but it is very, very painful. Now, a partial thickness burn is into the middle area, and this is usually hot liquids or a hot fire, flash type of fire that gets you, and it is very moist. It's pink also, but it's very moist in nature, not dry. It's characterized typically with blisters, or even if the blisters have popped, the water inside the blisters makes it moist. It is very painful, and it will heal on its own in about 21 days. When you look at this picture, in looking at this hand, you can tell where the burn is very moist. It looks wet. The tissue is raw, and it appears to be wet in nature. It is not a dry looking skin. It's a very wet looking skin. Of course, as the tissue is injured, it also tends to have swelling in the area of the burn. And then this foot, you can tell it's a very swollen foot, but it also is a wet looking burn. When you look at it, the top around there, you can see it just looks moist. If you were to touch it, it wouldn't feel dry, it would feel wet. So a partial thickness burn is very a wet, moist burn. And there tends to be a swelling associated with this burn. And we're going to talk more about the swelling, but with superficial, you don't typically get a lot of swelling with superficial burns, but partial thickness burns is characterized by swelling. And I love this picture because it's such a classic picture of swelling. I don't know what happened with this person. I picture him stepping on a campfire. Don't know that that's what happened, but in my mind, that's what happened. I can make up whatever I want. I'm the teacher. But that's what I always picture this as what's happening. Don't know if it is, but I love it. But I think it's a great picture. A full thickness burn goes even deeper, as I said, into the connective tissue, into the vessels, into the bone. And it's usually sustained. So it's it's not just a flash or a hot liquid that got on you and then you stuck it under cold water, but it still destroyed the tissue. It is sustained exposure to hot, regardless of the cause. And when it is sustained, it burns the nerves. It burns the blood vessels. And so there's usually basically no pain to this tissue because there's no nerve endings there. It's charred, it's leather, so it will look sort of yellow charred or brown charred or black charred. And typically it is because that it was, it's avascular. There's no blood vessels going to it. But it's brown and it typically is charred. So there'll be little pain. A full thickness burn cannot regenerate itself. It will not heal on its own. It will require grafting in order to be healed. So a full thickness burn cannot regenerate. Now, as kind of in the next picture in its own way, when you look at this top slide, this pink area around here is probably partial thickness burns. But these are the full thickness burn areas right here. So typically people don't always have just a full thickness burn. There could be partial thickness, which is very painful. It's surrounded by, that surrounds a full thickness area that got more of a sustained. So I'm not gonna say they're not gonna have any pain. This is probably partial all up in here. That is probably very, very painful for this person. So, but this area itself, if you touch this won't hurt them. But if you touch this, it's very, very painful to them. This person here obviously has very extensive full thickness. This whole patch, all of this is just avascular. This whole leg is just like almost dead type thing. There's probably patches that aren't, but there are patches that are. This is all full thickness. This is all full thickness. This is all full thickness on this patient. So this is a very serious burn on this person down here. So it's not just a spot or two. So it can be very, very significant burn on this person. But they're charred looking because it's completely just like charcoal, sort of. It's just completely nothing there, but just burned tissue more than anything. So that kind of looks at the difference. And this will not regenerate. A partial thickness will. Now, if it's a very, very small full thickness, now these are too big, but if it's a really tiny, let's say as small as maybe a half a pad of a finger, it might granulate in. It'll cause a scar, but it might granulate in around it and be able to sort of heal around it and leave a scar. But if it's bigger than maybe your whole fingertip, let's say, the size of a fingertip, it'll probably require grafting. But if it's really, really small, it might be able to just kind of drop in around it and make a scar and heal. But the area itself isn't going to heal and just look like it always did. So this would be a full thickness. So just to reinforce, the superficial is very dry, it's very painful, it's pink, it's red, but it's very dry, and it will heal in about 5 days. The partial thickness is wet. There's usually blisters. It is very painful, and it will take about 21 days, but it will heal on its own. And the full thickness is discolored. It's usually dark in nature. It is non-painful because you've destroyed the nerve endings, but it's very, very dry in nature. And so that's how they kind of look. And so they talk about the depth of the burn, and that's how deep into the skin and the tissues that it went when they talk about the depth of a burn. Just a couple more pictures of different ones. Number one is partial thickness. So it's very red, very moist, a lot of tissue damage, but very moist. And of course, B is full thickness and of the hand. And you can see these areas of vascular, and just even this looks charred. It looks bad. And even this is actually a full thickness scald burn to the buttocks. And it doesn't look as black, but except back down in here it is, and probably has some partial thickness around the side. This is probably when we talk about testing the water before setting these older people in hot water. Probably got really, really hot water and sat down right down into it. And we scald them in their butt. And we have to be very, very careful of that. So we talk about that. So depth is part of it. The other one is how much tissue is involved. Not just how deep, but how much. And it makes sense that the more tissue involved, the more serious the burn is. I mean, and so, I don't expect you to remember the percentages on this really, but it just makes sense that the more tissue involved, the more serious the burn is. So typically in less than 5% in 15% in adults, which is about an arm, okay? Well, maybe a little bit more than an arm, but it's probably still okay. I mean, we would call that a minor burn. If you were to partially burn, if you got a spill that completely burned an arm, it would still be considered a minor burn, unless it was a full thickness, and that's only about 2%. 2% would be like 2 of your hand sizes, and that would be considered a burn that would need to be seriously taken care of, probably in a hospital setting. Most minor burns do not require a hospital setting. Okay. The more burn tissue that's involved, the more you have to go. So partial thickness going up to 15 to 25%. We're now looking at probably a moderate burn. Okay. And many moderate burns will be in the hospital to start out with, and then we'll get you stabilized, and then you won't stay in the hospital for very long. But if you're a major burn, it will require long-term hospitalization. And so a major burn is a partial burn of greater than 25% in an adult, or a full thickness of greater than 10%. If you got a significant partial thickness burn of anything on your face, ears, eyes, feet, perineum, that requires hospitalization. Any inhalation injury, we're going to talk about inhalation injuries, an electrical injury, or any other concomitant injury, like if you got a shock and you fell off a roof and you broke your femur. If there's a concomitant injury that goes along with it, or you were in a trauma and the car caught on fire, anything like that would involve hospitalization if there's other problems. I was reading something about with perineum, partial thickness perineum burns have like a 90-some% death rate. It's very, very high because they all get infected. You all poop. We all poop. Come on, we all poop. Whether you admit it or not, we all poop. So, and they if you got a perineum burn, they almost all get infected, and then you get septic. So that's very, very serious. So the more the burn, and then we start adding other areas, it makes you at higher risk, which makes sense. So when we look at these patients, we're going to look at the percentage of their burn area, how much of their bodies burn, what's the depth of the burn, which we've already talked about, where is the burn located. 9% on from my knee to my foot is a whole lot different than a 9% from my neck to the top of my head. Because my airway is there, my neck is there, my eyes are there. Where is the burn located? If it is from pretty much my mid-chest up, that is a burn that we have to be very, very careful with. Not as concerned, unless it's our perineum, we're not as concerned about burns on the lower part of the body as we are on the top of the body, unless you've got a perineal burn. So if it's on your thighs, we're not as concerned as if it's on your neck and your face or your upper chest. Because I don't know if my shirt was on fire, did I suck in flame as my shirt was on fire? So where is that burn? You always want to pay real close attention to how the scenario on a test question, whether it's me, whether it's NCLEX, I don't know, or even on a patient, where is that burn? How do they describe where it is? Makes a big difference on how I worry about this patient. Is there any inhalation injury involved? And we're going to talk about that. What's the age? The very old, the very young, and those with a medical history, a chronic injury, illness do not do as well as those without. Do they have COPD? Do they have AIDS? Do they have diabetes? Do they have renal disease? Chronic illnesses, liver failure. What are your chronic illnesses? Do they have a history of chronic illness? They will not recover as well as someone that doesn't have those chronic illnesses. They just don't do as well. That's just the bottom line. They don't do as well. And then, is there any other concomitant injuries involved? So that's all part of how well are these people going to recover. You got to put it all together. It's a total picture. It's not just one factor. It's a total picture of who's going to do well and who's not going to do well. So when we look at the percent of burned area, the most common thing that's used is the rule of nines. And you do need to know how to compute the rule of nines. Now, the rule of nines here and the picture that's classically used is the one that you see here. Now, I like to teach it as 11 parts of 9. It's the same rule of nines. I just break it into 11 parts, right? And so I say there's 11 areas and each one counts 9%. So your entire head is 1. That's 9, 1. Your entire arm is 1. That's 2. Your other arm is 1. That's 3. The top of your chest, from your mid-chest up, is 4. From your mid-chest down to your perineum is 5. Okay? The top of the middle of your back to the top is 6. The middle of the back to down to your butt, down through your butt is 7. 1, 2, 3, 4, 5, 6, 7. The front of your leg is 8. The back of your leg is 9. The front of your leg is 10. The back of your leg is 11. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 times 9 is 99, and then your crotch is 1. That makes it 100% of your body. Now, if it's, you can divide the chest, the right side is 9, the total right side is 9, the total left side is 9. You could say your total leg all the way around from the knee down is 9, and your total leg from the knee up is 9. You can divide the leg front and back. You can divide it bottom half and top half, however you want to divide it. Okay? But I usually can sit there on the test and go 1, 2, 3, 4, 5, 6. Where am I? And count myself off for the rule of nines. So you need to know how to figure out, using the rule of nines, what percent of body burn we're looking at in a patient. Now, for smaller burns or real irregular shaped burns, they'll use what's called the palmar surface burn. And the palm size of the patient, not you, because if it's a baby, your palm's a lot bigger than a baby's palm. The palm size of the patient is about 1%. So if you were to go, okay, this little thing, it's about 3 palm sizes. That'd be 3%. It's an estimate. It's just an estimate. But it kind of gives you an idea of how big the burn is. So these are typically on minor burns to get a small size. Typically, if it's a bigger burn, use the rule of 9. But I do know on NCLEX, students have said, "Oh, Janie, I had the palm size." They say you've got a burn that's 4 palm sizes. What % burn is that? Somebody said they had a question like that on NCLEX one time. Just to let you know, I don't know if you care or not, but that was just another way of sort of estimating % of burns to kind of what size burn are we looking at here. So a very specific kind of burn is an inhalation injury. And there's lots of different kinds of inhalation injuries. One would be due to flame, due to fire. And so there would be some clues that would let us know that maybe this person had a burn inside of their respiratory system. One is their nasal hairs are singed. You look up, especially some man that has big old bushy big old bushy hair and stuff. You look up and their nasal hairs look all scrunchy in there. Maybe they singed their nasal hairs. They probably sucked in a flame and probably burned their nasal hairs. Maybe they actually have burns around their mouth, or if you open it, they look like their tongue is burned, or you see some burning in the roof of their mouth. So look inside their mouth and see, do you see any burns inside their mouth? If they have burns around their neck or their face, there's a chance that they were trying to breathe while the fire was there, and maybe they sucked in fire that way too. So just the fact that they have the neck burns or face burns could indicate they could also they're at risk for an inhalation injury. If they have a change in their voice, and the most common change of voice when the vocal cords gets burned and they get hot, they start to swell. And when vocal cords swell, they start to whisper. They start to get a little bit on the corset and they start to whisper. So if your patient starts to whisper for you or starts to get real rattly in their voice and they start to whisper like this, that is very typical of burned vocal cords. And those vocal cords keep swelling till they swell shut. They can also start to cough. And when you cough, instead of nice, clear or yellow or white sputum, it has gray and black stuff in it. And so that could be they're coughing up soot. They kind of sucked in soot, charred stuff. And the fact that they were burned in a confined area. When medic or the fire department brings them in and they will tell you where they found them. They were trapped in the bedroom. They were trapped somewhere. Were they burned in a confined area? It doesn't have to mean they were burned in a confined area. We're going to talk about carbon monoxide in just a minute, but noxious fumes, smoke inhalation and noxious fumes are found in people that are in confined areas. I don't worry about people that stepped on the campfire. They don't have smoke inhalation. It's people that are in confined areas that get smoke inhalation. So it's important when we would get burns in, tell me where they were burned. Tell me how they were found. That's important to anticipate what I'm going to find with this patient. So all of those can be indicators of inhalation injury. So one kind of inhalation is fire, is heat. The other one is noxious fumes. And the most common that we get is carbon monoxide. Now, carbon monoxide is due to incomplete combustion. And we see this a lot when the weather changes and people use space heaters and people have their furnace come on for the first time and that type of thing. And so what happens is they get more carbon monoxide in their body. And carbon monoxide, which is CO, your hemoglobin loves carbon monoxide. It loves it. It loves it so much that when it has the choice when you breathe of picking up carbon monoxide or picking up oxygen, it will say, oxygen, I don't love you. I love carbon monoxide. And so your hemoglobin will pick up the 4 things of hemoglobin on your hemoglobin will pick up carbon monoxide and leave the oxygen sitting out in the atmosphere. And so you asphyxiate, you become hypoxic. because even though there's oxygen right here, there's oxygen in this room, no one's choking me, but my hemoglobin does not pick up the oxygen. It picks up the carbon monoxide because it has an affinity for carbon monoxide. Now, these patients come in with a very classic presentation that everybody pretty much knows. They come in with this hallmark cherry red color. So they don't look blue. They are not cyanotic. Even though they're asphyxiated, they are not cyanotic. They are cherry red. And they have a cherry red nose, they have a cherry red lips, and they have cherry red fingertips. However, that is not the first sign. It's the one everyone knows, but it's not the first sign. The first sign is central nervous system involvement. And it can be anywhere from a headache to seizures, or headache to double vision, to confusion, to seizures, to death. And I will tell you that in the ER, when the seasons change, a good ER with good triage nurses recognize it got cold tonight, and it's one of the first nights it's got cold. Everybody that comes in with a headache, and we get lots of headaches, and you just sometimes you kind of blow them off. This is somebody we need to look at closer, because is this headache, have they been home alone today? And now somebody came in from work and they're like, oh my God, I didn't cook dinner because my head has been killing me all day today. That is classic. That is classic. And you know what? They get put in the waiting room and they sit for 3 or 4 hours and their headache goes away because all of a sudden they're breathing good oxygen. And then they're tired of waiting. They're pissed off because they've waited for 4 hours to get taken back to the treatment area, and they go home. And they go home and they all die because the house is full of carbon monoxide. So we know that when the weather changes, when people come in with headaches, it is very important that we don't just send them home back to their house, that house has got to be checked for carbon monoxide, that we check a test that's called a carboxyhemoglobin level. It's done just like an ABG, but instead of running an arterial blood gas, we run a carboxyhemoglobin on them. And it will tell us how much carbon monoxide is in their blood. And if their carbon monoxide is high, well, the first thing we say is, who else is in the house? And they'll usually say, well, my children are there with their older sister. Get them, tell them to go out of the house right now. And we've called and nobody answers the phone. I've only had that happen one time, but the kids were dead. All the kids were dead in the house. But the mom and dad were in the ER because the mother had a tremendous headache. I've only had it happen once. Thank God I've only had it happen once. But the minute we got her and the minute we ran a carboxyhemoglobin on her, we said, call, get them out of the house now. But nobody answered the phone. And neighbor went in and found all the kids dead in the house. So, it's very important. So a good ER nurse knows that at the change of weather, anybody that presents with a headache is very significant. I do have to tell you again, one of the students said, Janie, I had on NCLEX a question that asked about carbon monoxide poisoning and what's the important sign. And she goes, and I had the answer was headache. And she said, the whole time I just heard you on my shoulder telling about the headaches and the family. And she goes, and I kept saying, I know the answer, Janie. And you were just on my shoulder. And I kept saying, I hear it. Just get off my shoulder. I hear it. I see it. I know the answer. Just get away from me, Janie. She said, but the answer was right there. And so headaches and CNS manifestations are very, very important and first signs of carbon monoxide poisoning. Okay. So how do we treat carbon monoxide? We give you high flow oxygen. We put 100% O2 on you. And so now you have no carbon monoxide coming in, and it starts to pop that carbon monoxide off those hemoglobins, and it replaces it with oxygen. If your level's really, really high and you're unresponsive, we might have to intubate you and give you 100% under ventilation. If it's really bad, we may even have to take you to a hyperbaric chamber and give you oxygen under pressure. It's all depending on each individual client and what they need. but we've got to get high oxygen going and try to replace the carbon monoxide with oxygen. So that's carbon monoxide. Okay, so when you have a burn, you will, and you have injury to the tissue, you are going to have swelling of that tissue. And I'm going to talk more about it in the other tissues in just a minute, but you're going to have swelling to the tissue. Swelling of all tissues will be at its peak in 24 to 48 hours. So if you burn your airway is going to start to swell, and within 24 hours, it is going to be at its maximum swelling at 24 to 48 hours after the burn. All right. So we have got to protect your airway. Airway. If you have anything that we think is an airway injury, you must be intubated, and we're going to protect the airway. 24 to 48 hours later, the swelling is going to start to go away, and we can probably get you extubated. But if we wait until the swelling occurs, we will not be able to intubate you once the swelling occurs, and we might lose you. We might be able to trach you, but we don't do that. This was a long time ago, and most of you are not old about this, but in Hamlet, there's a chicken plant. And I don't know, it's a long time ago. Many years ago, the chicken plant caught on fire. And we got a lot of patients. I worked that night of the chicken plant fire. We got a lot of patients that came in, and most of them were smoke inhalation. Almost all of them. Very few of them had burns. A lot of people died at the scene. A lot died because they had the emergency doors were chained shut. And so the people couldn't get out of the plant. And they died of just not masses, but a lot of them died at the doors because they couldn't get out. But the ones that they brought in, very few of them had any burns. But because I can remember, I can see the ER as I'm sitting here talking to you all. But almost all of them were coughing, and almost all of them were whispering. We could tell that they were all getting laryngeal and edema from the burn. And I can remember all 6 beds in the major area. And major was different then, but in the 6 major beds, and I don't know what was happening out in the hallway, but in the 6 major beds, we went across to every single one of them and electively paralyzed and intubated all 6 of them that we got in at the same time from the Hamlet plant. And not one of them had a burn, but all of them were whispering. We said, get them all intubated now, or we're going to lose all of them. And I can remember intubating all 6 of those people during that fire. Yes.
Would you be intubating like as soon as you hear whispering, like knowing that it's just going to continue swelling?
Would we intubate before while they're whispering?
Yeah.
Yes, that's when we would do it. We want to do it before they get to the peak. The minute they were whispering, we knew they were starting to get in trouble, and so we would intubate them then. Yes. The minute we suspect that, we start to do it. Yes. But I can remember us doing that to all 6, and they were all alert. Every one of them were alert and oriented. And we were like, we got to sedate you, we got to paralyze you, and we got to intubate you. So, head a bed up unless it's contraindicated. So this guy right here, you can see over here, this is what he looked like when he came in burned in A. And this is 24 hours later, what he's going to look like when all the swelling of his air. So this is what he looks like on the outside. Imagine what his airway looks like on the inside. This guy, I have to tell you, this one, on a scale of 1 to 10 of what I've seen, he looks to be about a 2. I have seen tongues swell that would probably touch about right here on an ET tube that comes out of people's mouths. I have seen eyelids that swell out and they will puff out, and they'll puff out that far from eyes, and I've seen heads that were big as basketballs that just swell and swell and swell. Hang on, I'm gonna let the dog out. Come on, Zoe, hurry up, I'm busy. Go. I didn't know she was under the bed. So this is pretty, in actuality, this is pretty minimal swelling. I'll let you know. I would, when I look, it's the best one I could find though. But you could see he had to be intubated. The guy in A is not intubated. The guy, it's the same guy in B has been intubated because we knew swelling was coming up on this guy. But you got to do it. Got to get going on it. So you can have 3 types of smoke and inhalation injuries. You can have just carbon monoxide poisoning. You could have burns in the mouth itself, or you could have, smoke inhalation way down with a lot of crud down in their lungs. So inhalation down below the glottis. In that case, they tend to get they tend to get bronchitis. They tend to get pneumonia. They often have to keep washing their lungs out and trying to clean soot out of their lungs and that type of thing. So there's all different kinds of inhalation injuries, and all of them are bad. And all of them are concomitant if they have burns along with them. So that makes it even worse. So any type of inhalation injury is a bad, bad type of injury that we have to worry about. So when caring for the patient, there are different stages of care. And the first one is pre-hospital. This is before they come in at the site of the burn. What should we do? Well, stop the burn. That's probably the biggest thing we need to do is to stop the burn, put them out. Take as much clothing as possible off the person. Take jewelry off of them. Jewelry is metal, it stays hot. Typically in the burn unit, we had more patients lose their ring finger because people wouldn't take their wedding bands off of the patient. And that big old wide wedding band would cause problems. We lost a lot of earlobes from earrings type of thing. Jewelry needs to be removed at the scene as soon as possible, should be taken off. They should be wrapped in a clean sheet. Nothing fuzzy, so not like a blanket or anything that's really, really fuzzy that will stick to the burn. So take their clothes off of them and wrap them in a clean sheet. Don't worry about debriding them or anything like that, or don't put any burn ointments or butter or oils or anything like that on them. You can use tap water. If you're medic or something like that, you'll probably use saline or something sterile. But if you're at home, plain old tap water is fine. And patients will love tap water because the nerve endings are exposed and the air currents are going over them. And that's what's causing them pain. And that's why the old wives' tale of butter or the burn ointment helps. It's because it's like closing off the nerve endings and they're not feeling that pain because the nerve endings are covered. Well, water will cover it also. And so they'll keep saying, pour water on there, pour water, put more water on me, put more water on me. And it's because it's closing off the nerve endings. And it'll take about 24 hours for those nerve endings to atrophy down. And so it's okay to use tap water. It's okay to keep pouring tap water over them if they're hurting. It's not a problem. If it's greater than 10%, and 10% is pretty big, you can use ice. You can put ice. So if you were to like burn your finger on the iron or something like that, ice is a good thing to put on there because again, it cools the burn, but it also kind of numbs the nerve endings that are exposed. But greater than 10%, you should not put ice on. You really want to avoid butter. You really want to avoid burn ointment at first because it tends to harbor and keep bacteria stuck to the burn. So don't be using any burn ointments at home for larger size burns. If you just have a little tiny one, it doesn't matter. But if it's a bigger burn, don't be putting burn ointment on it because it tends to cause bacteria to stick to it. So pre-hospital, just stop the burn, cover it, and you can use plain old water on it if you're at home. But don't put anything fuzzy over it. Okay, so then we have the emergent phase. And this is at the beginning of the burn. There's no specific time frame, but there is a point at which it stops. But this is emergent. First, airway. Do we have any evidence of an airway problem? We're going to look for all the signs of inhalation injury. And is it from the middle of the chest up? We're going to assume there is some type of inhalation injury. If it's on the feet or the bottom down, probably not. But if it is mid-chest up, then we've got to ensure that they have a patent airway and give them some oxygen. Again, if they burn themselves from the bilateral knees down, they probably don't need oxygen. It's probably not an airway problem. So airway, breathing, circulation, always in that order. Always, always, always. We use that order on everything except for CPR, which is CAB, but everything else is airway, breathing, circulation, disability. Always, always, always. After airway and breathing are helped, we're going to then put large bore IVs in them, and we're going to begin fluid resuscitation. And I'm going to talk about fluid resuscitation in just a couple minutes. Okay, I'm going to talk about how much fluid do we give these people. We probably sit them up unless it's contraindicated, like they fell off a roof, then we couldn't sit them up. But if there's no other contraindications, sit them up, drop their lung fields, give them the best chance of breathing by sitting them up in a high Fowler's, and again, keep assessing them for where their burns are and do they need intubation. Get their vital signs, just get a good assessment on these people, but airway, breathing, circulation type of thing, and then give them a tetanus. Tetanus is very important. Tetanus is life-threatening, and once they leave the ER, very few people think of tetanus once they leave the emergency department. We think of it like it's a good brother, but most people do not think of it. So we always want to think of tetanus because it is a life-threatening. If somebody gets tetanus, they'll probably die. So any type of injury that needs tetanus, we're going to give them a tetanus tox, okay? Now, the emergent phase is the period of time required from the beginning of their burn, the beginning of their problems, until diuresis begins. That's the definition of what is the emergent phase. Okay, till diuresis begins. When is diuresis? Well, it's different for different people. All right, so typically we're looking at probably 3 to 4 days. It can go up to 7 days in some people, but it is typically 3 to 4 days is how long it takes for diuresis to start. Now, all these next pages in your slides is pathophysiology, and I'm going to talk about it. And it's important, but this is not a pathophysiology course. So I wrote this down for you because I want you to understand what's happening to your patient. But I'm going to tell you in a nutshell about what's really happening to your patient. Okay, so I'd rather you really listen to me instead of be writing it all down if you want to know the truth, because I wrote it down for you. So your patient gets burned. The tissue, I'm not talking inhalation now. Now I'm down on the body, okay? The patient gets burned. The tissue gets burned. When the capillary bed gets burned, the permeability of the capillary bed increases. What does that mean? The holes get bigger. The capillary beds are destroyed. So fluid starts to leak out of the circulating blood volume into the interstitial spaces. Okay? That's what happens in burns. Now, when the tissue gets burned, the cells start to pop. They get hot and they pop. Now, the most common cation inside of cells is potassium. You learned that in A&P. Well, you were told that in A&P. I don't know if you learned it or not. But the most common cation within the cell is potassium. So when you start destroying the arm because it got burned, or start destroying the chest because it got burned, potassium is going to get released from the cells, and it goes out into your circulating blood volume. If we were to test your potassium level, it would be very high because we destroyed a bunch of cells from the heat, okay? We do not treat that potassium level unless they're symptomatic. Symptomatic would be throwing a lot of PVCs. We do not treat it because as the capillary beds get burned and they're destroyed, fluid, remember the foot that stepped on the campfire? As the capillary beds are destroyed, fluid starts to leave the circulating blood volume and goes out into the tissues. The foot got big, the head got big in that man, and your patient starts to blow up like the Michelin Man. Well, as that fluid went out, the potassium went out. Now, when I test your blood level, your potassium is low. Why? Because all that extra potassium is now sitting out in your tissues. Now, about 24 hours later, 24 to 48, some people 3 days, some people 4 days, some people 5 days, but at about 24 to 48 hours later, the capillary beds start to heal. And now the fluid starts to come back into the bloodstream. And what do you think happens to your potassium level, somebody?
Goes back up.
It goes back up. We do not treat that potassium level unless they're symptomatic, because now they're ending the emergent phase and it gets to their kidneys and they start to diurese it out. And as they pee, out goes the potassium with it. And now their potassium level is normal. So we're going to have changes in potassium, changes in electrolytes, change of things, but we know over the next 24 to 48-ish to 36-ish hours, different for different people, we're going to have this huge shifts that are going on. And as long as our patients stay stable, we're not going to treat them. Because if I was to say, oh gosh, their potassium's high, give them some K-Exolate. And then you know what? I lower their potassium, then they move it out. Now all of a sudden their potassium's so daggone low, give them some potassium. And then 24 hours later, oh my God, they're high again, get rid of it. No, just, they'll do it. They'll get rid of it. Just, it's okay. Let the body do what the body needs to do. It will do it. Okay, so we're not going to fool with the potassium levels. We know they're going to go high, then low, then high again. And then you're going to pee them out. You're going to diurese it out. We know that. We know that. All right. Now, as that fluid moves out into the tissues, remember the big foot, remember the big head? As that fluid moves out into the tissues because of the burned capillary beds, that fluid came out of the circulating blood volume. I think it's on this thing. There it is. It came out of the circulating blood volume. So your patient, even though they're swollen up and they look like the Michelin Man, the Marshmallow Man, they are actually in hypovolemic shock because that fluid came out of their circulating blood volume. It's trapped in their third space. It's trapped in their interstitial space. But their cardiac output is down because it moved out of their circulating blood volume into their interstitial space. And if I don't replace their circulating blood volume, they will cardiac arrest and die. Even though they look like they are in fluid volume excess, they are not. They are in fluid volume deficit.
So, Miss Janie.
Yes, ma'am.
Was this caused, was it acute respiratory distress syndrome? Is this one of like the trauma things that would cause that?
Could be. If their lungs got underperfused, we're not going to let that happen. But if they did, the answer would be yes. It could, yes, absolutely. But we're not going to let that happen. Like this one says, body responses to early posterior general organ hypoperfusion. If we don't replace their fluid, their lungs could become underperfused. So could their kidneys, so could their uterus, so could their brain, so could their anything could become underperfused. But we're not going to let that happen. We are not going to let that happen. If adequate fluid replacement occurs, cardiac output usually returns to normal in about 24 hours after the burn. If we can support them for 24 hours, if we can keep enough circulating blood volume for 24 hours. The capillary beds will start to heal. They'll start doing their job. They'll quit that leaking out, and it will maintain its own body. It's going to need some help for 24 hours, but for 24 hours, we got to help them. But after 24 hours, and that's the critical time, we need to help them. Oh, that part I'm not worried about. Okay, so what do we got to do? The most critical time is the first 24 hours. We got to replace their fluid, and we got to keep them in fluid balance. How do we know they're in fluid balance? By their urine output. Their body, their body looks like a balloon, looks like a basketball. They're huge. Their body doesn't tell me. I don't know what their circulating blood volume is. But if there is enough urine, if there is enough blood to perfuse the kidneys, there's enough blood to perfuse the heart, there's enough blood to perfuse the liver, there's enough blood to perfuse the brain, there's enough blood to perfuse the uterus, the bowel, the lungs. The way I know is a normal or at least minimum urine output. Minimum urine output is 30, normal urine output is 60 mLs per hour for an adult. So I want to keep my urine output between 30 and 70 mLs per hour. I prefer about 60. As long as my patient is having normal to normalish urine output, I know they have adequate circulating blood volume. That's the key, because their body, this huge, big ballooned body, doesn't tell me anything. How do I know that they have adequate circulating blood volume? Their urine output tells me that. Their urine output tells me that. All right, it is 1:02. I'm going to see y'all back here at 1:12, and we're going to talk about, so how do we make sure they have enough urine? All right, we know how to measure it. How do we keep that? I'll see y'all back here at 1:12. Okay?
yeah, Janie.
Yeah.
I was gonna ask this earlier, with in relation to the preceptorship.
Yeah.
What were the units that y'all ended up on last time?
Oh, I don't know. There were
Just everywhere.
30 of them. I don't know. We ran 30 of them.
Yeah.
We are doing COVID units this time. Last time we did not do COVID units,
Okay.
even though we ended up doing COVID units. I mean,
Yeah.
once
Everyone's a COVID unit.
it just got to where everyone ended up having COVID patients, even though they weren't designated COVID units. And the thing is, you would have patients that you took care of yesterday and today they're COVID.
Yeah.
And so everybody's fit tested, everybody wears correct PPE. So we are not differentiating whether they're COVID or whether they're not COVID. We will take care of all patients.
Cool. Yeah.
Jane,
I was just curious.
Question. Sorry, I just had a quick question about reading in the textbook. When we are reading through those sections, do you want us just kind of I know there's some topics we don't go over in class. Do we need those topics, or are they just kind of just to understand
Just
everything?
the topics in class.
Okay. Thank
There
you.
may be more information than I present in class. You could be responsible for that. But let's say, I don't cover lung cancer.
Yeah, and there was something like.
But the biopsy that's done to determine lung cancer, you would be responsible for. But the different kinds of lung cancers or
Okay. Yeah, there was
cancer topic.
idiopathic pulmonary fibrosis. I didn't think we went over that. So okay, I just want to make sure we didn't need to still. Okay, thank you.
No problem. So I couldn't tell you what kind of units. We asked for any units they will send us. Let's put it that way.
Yeah, I just wasn't sure. I wasn't sure because I know the primary focus of this class is critical care.
Yeah, we
But-
we get some ICUs sometimes, but sometimes we don't.
Yeah.
We take them if we get them,
Yeah.
and we go to ICU if we get them. Last time I was surprised we did get some PICUs last time, and usually I get no
Yeah.
PICUs, and I got
I
PICUs
saw
this
some.
time.
I saw 2 students on the on the PICU when I went there.
I haven't had a PICU for probably 6 years. I bet I haven't been given PICU for 6 years, and I got PICU last time. I think we got 4. And so I don't know, I was shocked when we got PICU, but we got no ORs and and I doubt that we'll get any labor and deliveries. We didn't get any NICUs. We didn't get any MPCNs. We only got, other than 4 PICUs, we got 1 PEDS bed. One total. Most is going to be med surge. By far, let's see, this is Jane.
Med-surg, maybe ER.
Do they do that mostly based on the new grad hiring stuff, or is it just kind of random wherever they want?
Well, a lot depends on, they send it out to the nurse managers and they say, we have this many requests for preceptors from Carolinas College, but you got to remember, they also have it from we are the only, unless this has changed recently. Well, I don't have a lot of time to talk. We're the only state in the union that requires a preceptorship. So every single nursing school in North Carolina must do a preceptorship. So they're not just getting it from us, they're getting it from every single school in Charlotte, every single school in surrounding areas. And so they're going to send to the nurse managers, they're going to say, we got this many requests for preceptorships. Who can you take, and who send me as many as you can take. And so it's just sort of hit and miss. But labor and delivery isn't taking anybody because of the high exposure. They're just not, unless it changes. And if it changes, we'll use it. I mean, we'll do it. It's not us. We'll go wherever. But right now, I don't think labor and delivery is doing anybody. NICU's not doing anybody. MPCN's not doing anybody.
Janie, one last question for you about that, because I know you have to start.
Uh-huh.
Once you guys get those units, how do you then decide who gets those spots?
There is no rhyme or reason. There is no rhyme or reason on how we do it. None. I mean, there may be a little bit of rhyme or reason. I mean, there is some, but not as a whole, there isn't. We do kind of look at grades sometimes, but as a whole, we don't. But there is some. I have to be honest, there is some. But as a whole, no. It's just, oh, look, Susie Jones is next. Oh, look, I have a spot on 10 Towers. Susie Jones is going to 10. Oh, look, Janie McCluskey. Oh, look, I have one in Pick You. She's going to pick you. It doesn't matter. I don't know you all from Adams Hascat. I really don't know you at all, so it doesn't matter. There's no rhyme or reason.
Okay, thank you.
It's sort of hit or miss. It's amazing to me how many times people go, I really wanted to go there. Okay, good for you. I don't know. Maybe it's just karma. I don't know. Okay, so how do we replace this? Within the first 24 hours, fluid resuscitation is one of the most important things. And so we use what's called the Parkland formula. Now, this is a standard of care. I'm going to say nationwide. It might be worldwide. It comes out of Parkland Hospital in Dallas, Texas. And it's called the Parkland formula. And yes, you have to memorize the Parkland formula, okay? So it's 4 mLs of lactated ringers times the percent of burn area times the kilogram of body weight. And so I've got an example about 6 bullets down. So it's 4 mLs, which is standard. And this person weighs 75 Ks. So I said 4 mLs times 75 Ks times 50. It is not 0.5. So we're not changing it to a decimal point like for 50%. It's times the percent, 50. Okay. So this person over the next 24 hours is to get 15,000 mLs of lactated ringers. It's a huge number. Yes, because we must maintain their circulating blood volume. We will give half of that over the first 24 hours from the time of the burn. Okay, so half of 15,000 will be 7,500 mLs over the first 8 hours. Okay, oh, excuse me. They're to get half of that over the first must begin over the first 24 hours. Half is given over the first 8 hours. Yes, over the first 8 hours. You're going to give 7,500 over the first 8 hours. Okay? And then the other 7,500 is to be given over the next 16 hours. So it slows down a little bit after the first 8 hours because already the capillary beds are going to slow down and they're going to start to be repaired. It repairs over the first 24 to 48 hours. So this is a standard. And how do we know it's enough? Somebody tell me, how do I know if that's enough fluid?
Urine
They're
output.
urinating.
Your urine output. If they're only putting out 10 mLs, I got to get on the phone and say, not enough. Got to call the doc. I say, we're doing Parkland. It's not enough. But it usually is enough. This is sort of a standard of care that says that if they have that urine output, then they should have enough circulating blood volume. So it's urine output between 30 and 70. They should also have a normal blood pressure, which sometimes can be hard to measure because of their fluid. Their arms are puffy and that kind of thing. They should not be tachycardic or maybe just a little bit tachycardic. So we would like a pulse less than 120, which if it's 110, that is tachycardic, but sometimes they are a little tachycardic. And their lungs should stay clear. I don't want them in fluid excess. But we really look at the urine output. That's probably the biggest thing. Now, if you remember, I said every single system is affected. So let's look at some things that get affected. Well, the cardiovascular system can be affected. They can develop hypovolemic shock, which we've talked about. They can become hypoxic and they can develop arrhythmias. So they can go into tachydysrhythmias. They can have PVCs. They can have other dysrhythmias too, especially if they have a history of cardiac problems to start out with. It can potentiate the problems that they have. We can get circulation impairment. Think about that one full thickness burn of that leg and what kind of poor blood flow going to that leg. We're going to be checking for compartment syndrome. We're going to check for, do they have good blood flow? Do they have good pulses in their legs? And that type of thing. If for some reason that if if there's no poor blood flow because of that tissue is like leather, it's not expanding and contracting. It's got compartment syndrome. It's not allowing the tissue to expand and contract. We will have to open up that tissue, and we do what's called an eschorotomy. And I've got a picture of an eschorotomy in a few slides down the road here. And we simply take a cautery and we just cut the tissue open and give it some room to breathe, to basically room for it to expand and contract. But we got to have good blood flow, okay? Because with some kind of artery down there, we got to find somewhere down there that help. If not, they're going to just lose their leg. But if there's an artery flowing down there, we're going to find it. Renal, we can have renal problems. And a lot of this has to do with all of the myoglobin and hemoglobin that's being released from this dead muscles that have been burned. You get this myoglobin that's being released and all of these breakdowns of tissue that's being released. And so it's starting to plug up the kidneys, and they get what's called ATN, acute tubular necrosis. And so the kidneys are just getting plugged up, for lack of better things. And that's another reason why we need this high flow of fluid. Number one, to keep their blood pressure up. That's ABCs. But also, the thinner we can keep their urine, more on the 70 side instead of the 30 side, the more flow through their tubules you get, and the less acute renal failure, the less ATN that you're going to get. You try to keep the urine flowing through the kidneys instead of plugging up the kidneys from all the necrosis of the breakdown of tissues, the myoglobin, and all this breakdown of all the junk that's being just dead tissue of the internal organs that's just being broken down from the burning type of thing. As the hemoglobin and the myoglobin, the urine often is really dark, reddish brown in color. We sort of expect that, and that's just hemoglobin and myoglobin being broken down. Hematologically, the red blood cells burst, so they typically get pretty anemic afterwards, so often they need transfusions. They often get, also with dressing changes, they tend to ooze a little bit. And so quite often they're getting transfused about every 3 to 4 days. So they often are very much anemic just due to just red blood cells that's just been burned and just lost. So we see that a lot. Denuded skin tends to get infected easily. So their white count tends to rise. They get leukocyte count goes up. The burn also decreases their platelet counts. So a low platelet count causes them to bleed. Bleeding contributes to their low red blood cell count. So all of those are things that we're going to see. So their hematological system is involved. They're all written down here for you. And all of it was mostly because it was burned. So the emergent phase goes until, from the burn, when they get there, until they start to diurese. Now, once they start to diurese, from diuresis until the wounds are healed, is the acute phase. That's a really long time. So now we've pretty much got their cardiovascular system in place. The capillary beds have started to heal. I have adequate circulating blood volume. They're now diuresing all that 15,000 cc's of Parkland formula. We got to get it out of the system. They're diuresing that out. And now we got to start working on their wounds. Now, we've been taking care of their wounds all along. For the last 24 hours, we tried to keep them from getting infected. We've used sterile technique. We've been very careful, but now we're really and truly looking at caring for this patient, but not necessarily only the ABCs. We're still replacing their fluids as needed to keep their blood pressure normal, to keep their heart rate normal if we need to, but we're not seeing as much fluid shifts. At about 48 hours, the fluid shifts start to stop because the capillary beds have healed. The K starts to become normalized. It might decrease a little bit, but as a whole, we might just start now on maintenance fluid and add a little like D5.5 plus 20 a K, just sort of a maintenance to keep the potassium normal. And we start caring for the wounds. Now, wound care, typically, we've got to get at the old, dead, burned tissue off before new tissue can grow. And one of the best ways is well, these are some of the things we got to be looking at when we talk about wound care in general, and then we'll talk about them specifically. One is the hydrotherapy. We've got to wash off that old tissue, and we've got to pick off debridement, that old tissue. Some people say debridement. I learned debridement. We called it debridement in the burn unit. Okay. So we got to get the old tissue off. We got to keep them, their nutrition up. We can't let them get cold. Most of the time they're wet. Remember, these wounds are wet. They're wet. They're cold. They're big dressings, lots of body area denuded. They're in a lot of pain, unless it's all full thickness, which they'll probably die, but most aren't. Most have a lot of partial thickness with it. Their mobility, they'll start to get contractures as the skin starts to heal. So we want to keep them, their joints moving and their joints mobile. Infection, they're at high risk for infection. And we got to just keep caring for their wounds. So what do? First of all, hydrotherapy. They usually they need to wash their wounds at least once a day. If they go home, they should shower once a day. And they go in the shower and they should scrub their wounds once a day. If they're in the hospital, we typically put them in the Whirlpool tank, and it's called a Hubbard tank, once a day. And we scrub the exudate off of their wounds. Probably this is the part of the burn unit that I hated the most. We would put them in this tank, and we would have, I don't know, we'd either have betadine or salt or a Clorox in the water, just depending on what the patient needed, or vinegar. Those are typically what we used in the water. And then we would take the brush that is used to clean your fingernails before you go in the OR, and we would scrub their backs with not the soft side, but the hard side. And the patient would pretty much scream through the whole thing. And I hated it. But you had to clean all that gunk off of there because you wanted that dead tissue to come off. The patient, as long as they weren't intubated, if they're intubated, they didn't go to the tank. But if they weren't intubated, they had to get out of bed and walk to the tank, to like the other side of the room, a different room, because that's range of motion. We wanted them to walk. You didn't push them in a wheelchair. They had to walk. And then when they had to lift their leg up and lift themselves over into the tank, because again, that's range of motion. And when they would put their hands on the side of the tank, it would like split their fingers right here and it would bleed. But, if not, then their hands would start to web. And, then they wouldn't have use of their fingers after they healed. So we made them push down and crack their fingers every day and made them bleed where their fingers would crack every day. As they healed, we wanted them to push back and heal. It's quite difficult. It's quite a painful recovery, and it's pretty difficult, I think, for the nursing staff. I found it very difficult for myself. But we pre-medicated them to the best we can, but we couldn't have them zonked in the tub. I mean, then they go under, you're trying to bring them out of, keep them from drowning. Cross-contamination, almost everybody got the same bacteria because we scrubbed the tubs down, but they weren't sterilized. You couldn't sterilize the tubs. So it was very difficult. We saw a lot of cross-contamination as far as bacteria goes. But it was pretty rough. I found it rough. Some people love it, and I'm glad they do, because I think there should be something for everybody. God love a burn unit nurse. God love a psych nurse. God love an OB nurse, if that's what you love. God love an ER nurse. That's why that's the nice thing about nursing. There's something for all of us that we would love. Most burns respond better to topical antibiotics than IV antibiotics. They might get IV antibiotics, but they will almost always get a topical antibiotic. Burns respond very well to topical antibiotics. The most common is probably silver sulfadiazine. You probably know it more as Silvadene. Silvadene, patients love it. It is pain-free. It doesn't hurt. And it has the consistency, and I have a picture of it. It has the consistency of Noxzema. It sort of has a thick consistency. You put it on sterilely. Usually it's either out of like a toothpaste tube and you squirt it out on the sterile drape, or you can use a tub of it and you take a sterile tongue depressor and scoop it out and put it on the sterile drape. Then put your sterile gloves on, and then you can pick it up and then use it on your patient. sterilely, but that thick Noxzema thing sort of covers the nerve endings and it helps with pain. And patients really like it a whole lot. They think it's a great drug. They love it. The problem with silvers, well, that's one of them. The problem with Silvadene is it can cause leukopenia. It can cause them to drop their white counts. And so you have to watch it. If their white counts really drop below normal, we have to come off the silver sulfadiazine. And remember that NCLEX uses generics, so you should recognize, everybody calls it Silvadene. My dog who just got, she's a diabetic. She's newly diagnosed diabetic and her paws broke down. And I was like, oh my God, I got necrotic paws on my dog. They weren't necrotic, but they were bad. So we ended up at the vet and so the vet gets this tub out and she's putting this up. I goes, that's Silvadene. She goes, it is Silvadene. Do you know what Silvadene is? I said, of course I know what Silvadene is. But yeah, so they call it Silvadene at the vet, but it's silver sulfadiazine. Okay, it's the generic name, which you need to know for NCLEX. And Janie. So it is painless and it's good. Now, malphonide acetate is called sulfamylon. The trade name is sulfamylon. Now, this is a more broad spectrum. It doesn't usually cause leukopenia. The problem with this is that it burns. When you put it on, it gives a burning type of deep burn. It goes away, but when you first put it on, it sort of hurts. It stings. I've never had it, but the patients tell me it stings. So typically we will pre-medicate them and you sort of say, we know it stings, but it'll go away. Give it 30 minutes and the sting will go away. So it's more broad spectrum. And again, if they're having a problem and they can't tolerate the sulfadiazine, they may have to go to the malphonide acetate, which is a sulfamylon. We can use silver nitrate, and we typically use those sticks, like the silver nitrate sticks that you wet, and then they look like Q-tips, but they've got little hard things on the end. We use that for like those little small full thickness burns, and it will like burn through the eschar and so it'll help like burn through that. And it does have some antibiotic on the silver nitrate, but it will help with that. These other ones are just betadine and that type of thing. We could use gentamicin and nystatin. Silvadene is not used on the face or the neck or the ears or the penis. All right, because Silvadene can cause increased scarring. So if someone's getting Silvadene like all over their chest, all over their backs, all over their arms, all over their hands, we do not put it on their face. We simply use like a clear, like bacitracin or misotracin or some type of triple antibiotic ointment, just that clear, greasy looking ointment on faces. We do not use silver type ointments on faces because it increases scarring. So none of that on the face. But these are the typical type of antibiotics that we like to use, and they work very, very, very well. How do you get the eschar off? Well, we know that hydrotherapy works to get them off. Another thing is you can simply take your forceps and pick it up and cut it off. And of course, we do that real often, and this just shows one that is healing, but all this has to come off. All of this has to come off, and you can see, let me get my pointer up there. Pointer, go up. Do I not? Oh, I am recording. Okay, I thought I wasn't recording. But as you can see, this is probably where it kind of clipped it off, but that's good skin under there. Even though it's bleeding, that's good. We got good tissue under there, and it's probably going to heal on its own under there. But we got to get that eschar off of there before any grafting can take place or any self-healing can take place. So this can probably be scrubbed more tomorrow with the hydrotherapy, and then we can pick off anything that looks loose on there. You can also do dressing changes on it. And I'm going to come back and do here. And remember that wet to dry dressings are for debridement. You put the dressing on wet, you let it dry like for 4 hours, and then you pull the dressing off dry. And that will pull the dead tissue off with it when you pull it off. The finer the mesh of the gauze, the more debridement it's going to do. So if you use a 4x4, you'll get some, but you won't get great. But if you're going to use a 4x4, then fold it out and lay it down flat on top of it, and the tissue will sort of rise up and get in all the little holes of the 4x4. Let it, and then just cover it with an ABD pad or some more 4x4s or something. And then when it dries, you just pick it up and just peel it off, and it will cause debridement. A wet to dry dressing is for debridement. A wet to wet dressing, before you pull it off, you wet it back down, and you do not get as much debridement with a wet to wet dressing. It will probably debride a little bit, but not as much. But patients that can't tolerate wet to dry dressings will have to do wet to wet. I have to tell you, this is kind of personal, but I had a cyst removed off my back, and they left a hole in my back that you could put your fist in. And I had to, most of the time at work, I'd say, okay, come on, somebody come do my dressing. We just go in the lab. It's time to do my dressing. And they go, oh my God, Janie. But when I was at home, I would try to take my dressings off and then come to work and have somebody put it in for me. And I could not hardly, they wanted me to do wet to dry. I could not hardly tolerate, and I wasn't even infected. I could not hardly tolerate wet to dry. It was really different. I couldn't pull it off of there. I almost always had to just put it back in the shower and pull the dressing off as I was in the shower. And I think I have a great pain threshold. But I found wet to dry to be very painful for me. And so I would wet it down and cover it up and come to work and say, okay, somebody go to the lab with me and put my dressing back in for me. So anyway, that's kind of personal, but I found wet to dry to be very painful on a personal level. And this shows one all healed up. And as you can see, especially after, whoops, I didn't mean for that to do that. Especially after grafting, the skin looks much different. When you go to grafting, your skin will look much different, but it is covered and you are alive, but it does look different. If you have a lot of eschar and they're having trouble getting it off, they can also use an enzymatic product. Sutiliane is one of them. The trade name is Travace. And in this case, it's a proteolytic drug. And so you don't use your finger, you use a Q-tip. But you put this enzyme on the eschar, and it just sort of eats it, for lack of better words. It just dissolves it. If you ever use a enzymatic debriding agent, do not put it on good skin, because if it eats the good skin, it hurts a lot. But that dead black, brown eschar has no feeling. And so you can put it on that hard, scabby looking eschar, and it doesn't hurt at all. So it does pretty good. Typically, you put the enzymatic on there and then put a nice flat piece of gauze on it. And then when you pull it off, it'll pull off a lot of that eschar, and it doesn't hurt because the eschar has no feeling. But that's typically how you do an enzymatic. But just make sure you don't put it on good skin, kind of thing. And then about once a week, maybe twice a week, but usually about once a week, they'll take them to the OR, they'll put them to sleep, and they'll actually, under anesthesia, get down deeper and take out more tissue. So this says usually about every 72 hours, they'll start doing this. And then they will start to graft them. And once they start to graft them, they will use a donor site. They'll take good skin from one area and cover that area when there's no more dead tissue. It's got to be clean. They will then cover it. And using an autograft, using their own skin is the best. But sometimes they can use synthetic skin. Synthetic skin, like pig skin, for example, or porcine skin, doesn't work. It can't stay on forever, but it can cover it well, keep it from getting infected for a pretty long time, like weeks, a week or two. We used a lot of pig skin in Kentucky, where I was in the burn unit, especially like if they were on a ventilator and they weren't going to be able to be grafted for a while. We would keep it covered with pig skin until it could be grafted. Or we can use cadaver skin. Now, cadaver skin can last forever. It's grafted just like regular skin is. So somebody who died that donated their skin, we can use cadaver skin. As far as a donor site goes, donor sites are covered with a lot. They can be covered with a lot of different things, but most of the time, when they take a donor site, it's taken off with like what looks like a cheese cutter, for lack of better words. It's like sliced off, and then they take and they put a piece of gauze over it, and they just usually leave it open to air. It can be covered, but they'll come back from the OR with it covered, but then you take the dressing off and it just is covered to air. And that gauze forms like a scab, and it just hardens up and it gets like a scab. And we typically use something called Mercuroclear on it. And this just keeps it from getting infected. And you just kind of, as the ends as it gets smaller, the area will start to heal, and it gets smaller and smaller and smaller. And that gauze kind of starts to roll up and peel around the edges. You just take a pair of scissors and cut around it, because it gets caught on their sweatpants and gets caught on the shorts. And eventually, just like a scab, it just sort of gets smaller and smaller and smaller until it sort of just falls off. The donor sites hurt a lot, but the drier they can be, sometimes we'll put heat lamps on them, but most of the time it's like a scab. If you keep it under a Band-Aid, it stays soupy and hurts. But if you let a scab dry, it heals better and it just sort of falls off. And that's the way a donor site will work. The more to air you can keep, it'll dry up and it'll pretty much fall off. Now, a skin graft, and this is an example of a skin graft. Now, this graft is actually on this person. So this area up here is their normal skin. And this is the skin graft. So you can see it's going to look different. Grafted skin typically looks very different when you get it on the patient. And when they take it off the donor site, it's usually a very small piece of skin. Then they run it through a dermatome. They run it through a little machine. And the best way that I can explain this is, those of you that are OB lovers, those panties they give the women after they have a C-section that come out of the package and they're about this big, and then you stretch them out. They got all these little holes in them, and they stretch out to be this big for the big old fat women that just had C-sections. That's what happens with this. They take this little tiny piece of skin, they run it through, and they make all these little holes in it, and they're able to like triple or quadruple the size of that piece of skin. And then when they put it on, it has all these little holes in it. But they're able to take less size skin from the donor site and stretch it out to cover more skin on the burned area. And so it works well. So this is an example of what a healing skin graft would look like. You don't take it off. Don't peel it off the patient. When you have a skin graft, it stays on. If you ever do dressings, don't peel the skin graft off. Okay. Nutrition is, we're almost done. Nutrition is extremely important. Extremely important. And when you want to regenerate tissue, you give them high protein. And so we must increase the protein in the burn patient's diet. They should be high calorie, high protein diet. Very important. In our burn unit, we had our own kitchen, and everybody got the incredible edible egg. Every meal had an egg stuck on top of it. If you got a milkshake, we mixed it with egg powder, and we had to mix egg powder in milkshakes. We made milkshakes constantly. High protein was extremely, extremely important. You always want to increase the protein in their diet. Very important, because we want that tissue to regenerate. We do not want them to go into a negative nitrogen balance. Protein is important. Okay, Janie, come on. Can you go? Pain control. Pain control should be IV pain control until their gut really is working very, very well. We do not give IM pain medicine because that fluid shift has gone out. Fluids are not shifting in. So if I stick it in their tissue, regardless if it's not burned or not, I'm not sure when that fluid is going to shift back in. So we do not use IM pain control. Now, you all don't give much IM pain control, but when I was a first new nurse, that's all. You couldn't give IV pain nurse. Only the ICUs could give IV push pain medicine. So we gave IM all the time. And let me just tell you, there was not near the IV pain medicine abuse in the hospital because people only got IM pain medicine when they really needed it. But we do not give IM pain medicine to burn patients. We give IV pain medicine. Okay, treatment with the opioids of morphine and Demerol. They need it. They may need a continuous PCA pump for several weeks. This is how painful burn control is. It's very, very important that they get IV pain medicine for pain control. And then we will deal with it. But IV pain control is the drug of choice for pain control in these patients. Keeping the wounds covered will decrease the air going past the wound. This will also help with pain control. Other than the face, we typically cover the wounds. This will help with pain control. Changing the dressings often. The exudate coming out of the dressings, the liquids coming out of the wounds are irritating. They have potassium in them. They have a lot of fluid in them, and those are itchy, painful, burning exudates. So we typically have dressing changes every 4 hours. Even in these huge dressings that take an hour to do, 4 hours later, we're going to redo those dressings again. They are to help with pain, to help to just decrease the chance of infection, everything. So dressings are done really often. We don't want that leaky, wet stuff coming out of the burns being left on those burns. We want those off of there. So they're changed really, really often. And so that will also help with pain control. Yeah, changing the dressings hurt, but leaving it on also hurts. So we're going to do it to help both ways. So rehab, as I told you, was about 7 times longer than most trauma patients. They'll go to physical rehab once they're physically stable. We will, it'll be important for their contractures. So we want to get them back to their optimum level of functioning. We want their joints to move. We want them to be as optimum as they can. We're going to promote their nutrition. We're going to increase their protein intake. And we want to hopefully prevent their scarring and contractions with compression dressings. Now, they wear a Lycra type of dressings, and they will, I think I have this on a slide in just a minute. I'll pull this up in just a minute. So they will wear compression dressings to prevent scarring and their contractures. And we're going to have to deal with them psychologically. This is going to be a major change in their life. A lot of them feel guilt. They may have burned the house down. There may have been other people involved. They may have lost their job. The way they look is different. Psychologically, it's a huge deal. It's a huge deal. So not only just physical rehab, but they need psychological rehab too. It's an all-encompassing thing for them and their family. Their life has changed and will probably never be the same again. It will take between 6 months and 2 years for their skin to finally truly be at the point that it's going to be at. Anybody that has a burn, even if you have a small burn, you should not expose that burn to any sunlight for at least 6 months. If that area gets suntanned or sunburned, it will stay probably that color for the rest of your life. So if we know that they had even just if you're in the ER and someone has a burn or stitches, and that tissue is regenerating, let's just say it's the summertime, you tell them they have to keep that covered for at least 6 months when they are going to have sun exposure, because if they sunburn or suntan a suture line for 6 months, it will stay that color probably for the rest of their life. So it's very important that they do not sunburn or suntan any regenerating skin. The discoloration of their scarring will typically fade with time, so the discoloring it will get better. The scars will be raised, but they will flatten if they will wear their contour device, which is this Lycra. They have to wear that 24 hours a day for up to 2 years. So if it's their face, they're going to wear that mask for 2 years. If it's a total body one, they're going to wear it for 2 years. And they wear it to bed. They take it off, take a shower, and as soon as they take the shower, they put it back on. When these Lycra things first started, they were only for Caucasian. They came in one color and one color only. So if you were darker skinned or you were African American or you had if you were Caucasian but had a different colored skin, it didn't matter. They all came in one color. Now they don't. Now they're very good. They come and they match you up to what color is your skin now, or what color is your normal skin color, and they match it. So yeah, it still doesn't look the same, but if you're normally a really dark African American and had to put on a very pale peach colored type of device, it was very noticeable. But now you're going to have at least the same hue, the same color of a Lycra device. So, there's been great progress in that. So they do try to match the Lycra up to your normal skin color. So at least that's helped some with body image disturbance and that type of thing. We also got to avoid your joint contractures. We want you to have an optimum life, but man, if you can't move your arms, you can't move your legs, you can't move your fingers, you're alive, but we don't want that. So lots and lots of rehab, lots and lots of physical therapy, lots and lots of exercises. And it's not the easiest thing in the world, I will let you know, but it has to start in the hospital. It can't start in physical therapy. It has to start at the time of healing. And I told you it was tough. It's tough when you're breaking every day, you're breaking that area that's trying to heal to prevent that webbing. It's not easy. And the patient's screaming at you, please don't do that, especially when they're peds and that child is screaming at you. It's tough. It's a tough job. I respect the burn unit nurse tremendously. Teaching skincare, obviously, importance of range of motion. Letting them talk about their fears about their hospitalization, their fears about going home, their fears about what their family thinks about them, their fears about people seeing their scars, their fears about them seeing their compression dressings, just the fears about everything. Their diet, do they understand about their diet? What is high caloric? I don't like eggs, and that's all you ever feed me is eggs, the incredible edible egg. What other things of protein is there besides eggs? There are other things that are high protein besides eggs. Gerontological considerations, increased falls, pre-existing conditions, failing eyesight, smoking in bed, all the things that can go with this. So we got to look at all the different type of things. 75% of all burns are preventable. We got to watch them. House fires, smoking in beds, and alcohol and drugs are the #1 causative agents of burns. All right, y'all. I'm here if you need me over the next few days before you take the test. Take care. I'm here. I'll leave this on if y'all want for questions. Bye.
Miss Janie, I had a quick question.
Sure.
When you were talking about the garment that they put on their face or put on their burn, how did you spell that? The Lycra? How were you?
Lycra, I think.
Okay.
I
can look it up. I just wasn't sure.
The same stuff that bathing suits are made out of.
Okay. Thank you.
Janie, I had a question about respiratory.
Sure.
So for acute respiratory failure, I guess for an example, for a question on the test, would you ask us, would you say, oh, this patient has diffuse limitation? How would you treat them? Or is it kind of?
No, I told you, I'm not going to ask you those 4 conditions. I will not ask you those 4 conditions.
Okay.
Those were simply for your information. So I'm not going to make you differentiate. Is this diffuse limitation or is this impaired capillary, increased pulmonary shunting? Or I'm not going to make you do those. I promise you, I will not do that. As far as acute respiratory failure, remember that's a category. Tell me what the definition of acute respiratory failure is.
It's a PO2 of less than 60 with 100% oxygen.
Well, greater than 60. Okay.
Yeah.
All right. So it's hypoxia. It's bad gas exchange.
Right.
It's an overall statement. It's not a disease. It's a condition. Mm-hmm. It's a condition of hypoxia. It's a condition of poor gas exchange, right?
Yeah.
Okay, so that's when I say somebody's an acute respiratory failure, you should say, oh, they're hypoxic. They have poor gas exchange. Now, what's causing that is a disease or a condition like ARDS, pulmonary embolism, COPD, pneumonia, carbon monoxide poisoning, smoke inhalation. You know, those are all things that cause you to have a low PO2,
Right.
and the low PO2 is acute respiratory failure.
So then we would
I forgot what your question was.
we would kind of need to know like how to treat the symptoms that they're
Well, yeah, because if the problem is hypoxia, then your treatment is to get their oxygen level up.
right.
That would be treating it, but I'm not going to ask you about those 4 conditions. And I told you I would not do that. I just wanted you to
Yeah.
understand that's what is causing people to be hypoxic. Either their alveoli aren't open or their blood vessels aren't open.
Okay.
That's basically what those 4 conditions are. Or there's something that's making it more than 1 cell thick, like ARDS is more than 1 cell thick.
Yeah.
So do I expect you to know how to take care of ARDS? Yeah,
Yeah.
I do.
Okay.
I mean, it's acute pulmonary, it's acute edema, pulmonary edema, but it's not cardiogenic. So you got to try to keep their fluid volume down, but their blood pressure up. And then you got to work with the patient about hypoxia, and you got to work with the family that they're going to die.
Yeah.
Chances are they're going to die, or they're going to be really, really sick
So to get them out of ARDS,
if you can.
yeah, you would just mainly try to work on getting the capillary beds the holes to close.
Yeah, and you do that by keeping their blood pressure up, greater
Okay.
than 100, but you can't do it by increasing their fluids, because then you're going to throw their pulmonary edema worse.
Yeah. So then how? So you just
That's
have
why
to,
they die, because we can't do it. It's too, the line is too,
So that's different from burns in that you can't give them a ton of fluids because it'll cause their edema to get worse. Whereas burns, the edema, it is not going to get worse. Like you need to make it like you
not
need
their
to-
lungs, it's the problem.
Right.
In this case, if we don't give them a huge amount of fluid,
Mhm.
they're not going to have enough circulating blood volume, and their blood pressure is going to fall to nothing. Even though they're puffed up, their blood pressure is going to fall to nothing, and they're going to VFib and die.
Mhm.
So I got to keep their circulating blood volume up by
Okay.
dumping huge amounts of fluid in a burn patient.
Right. But then
Okay.
in the ADRS patient or ARDS patient, you want to keep their fluids up, but you don't want to give them too much. And that's why they die, because of the titration just not working.
Right.
Okay.
But when I say I got to give them fluids, it's because the most common cause was trauma, and they became in an underperfused state. So and that released the endotoxin. So I got to get their fluids up
Uh-huh.
to hopefully stop the endotoxin release.
Yeah. So would you want to
Because
deal
if
with
my
the
fluids
trauma?
drop, the endotoxins come out again. So I got to keep my fluids up. But if I give them too much, the pulmonary edema is worse. So I can't go above here.
Mhm.
But if I go down here, it makes the pulmonary edema worse because of the endotoxins. If I go up here, it makes my pulmonary edema worse because of too much fluid.
Yeah.
I can only go right here. And so it's really hard. And sometimes it just doesn't work. Most of the time, it just doesn't work.
So like to prevent it, would you want to deal with the trauma first?
The preventive is don't let them get underperfused. Don't let them get in don't let them come in with a blood pressure of 60 over 20.
Okay. So
Don't let them get in an underperfused state.
Okay.
Which is fine unless they're trapped in a car for an hour and a half and you couldn't get anything to them, but you didn't have a whole lot of choice.
Right.
But if you were in a situation, that you didn't recognize that they were in an underperfused state, or, well, we didn't take their blood pressure, or we didn't know that they were you're at Joe Blow ER that never gets a trauma patient ever, and they only see 6 patients a year.
Mhm.
Sometimes that happens, unfortunately. No, I'm exaggerating, but
Okay.
sometimes care in some places are not good. Luckily, that's not most places, but sometimes care is pretty poor.
Okay.
Sometimes.
Can mechanical ventilated patients get this? Like people who are ventilated repeatedly?
Oh yeah, a lot of them are some
it-
are already ventilated.
And
Because
then like,
not picked up what the cause was yet.
yeah, and then it's like, because one of the, I think it was pneumonia or something is one of the causes of ARDS, right? It could be.
Could
So it's
be.
like it's so they could catch pneumonia and then it could progress into them not being diffused enough and then they could go into ARDS. Could
They
that be
can't-
one
they
thing?
can. It can be lots. They'll just start developing pulmonary edema and
Okay.
can't get rid of whiteouts on the chest X-ray. And no matter what we do, their PO2s kept dropping, and we keep increasing our FiO2s, and now we're at 100% O2, and their PO2 is still 50. And they get pulmonary edema, and no matter what we do, it's just not working. And they typically die. And it doesn't have to be terrible. I mean, it doesn't have to be a bad trauma, I guess, all the time, but it does have to be an underperfused state. I usually tell the story, but I didn't today. I did today because I didn't want to get behind. But my daughter was a nationally ranked figure skater. I don't know if I've ever said that in class yet, but she was 4th in the nation. And every year we would go up to the University of Delaware because that's a big figure skating area. And we would spend the summer up there. So I'm in the stands. My daughter's out on the ice skating with all these people that go to the Olympics. And the #1 U.S. pair skating team is out on this ice. He's got her above his head in a thing, and he trips. And he tried to protect her, and as she came down, they both fell, and she fell on his head. And so she's okay. He's unresponsive on the ice. So I go flying out of the stands, and by the time I get to the bottom of the stands, he's seizing on the ice. And by the time I get on the ice, he's in full cardiac arrest. So I start CPR on the ice. And so he wasn't in arrest long, let me just assure you. I mean, I don't know how long he was arresting, but I would say it was probably no more than 30 seconds before I started CPR on him. And of course, the ambulance came. It seems like forever, but it probably wasn't that long. But we were at the University of Delaware, and he was taken to the University of Delaware Medical Center. So I'm sure it wasn't very long. But, and so I asked later, I said, does anybody know anything about him, about what's going on? And they said, well, I think he's doing okay. They said he's on a ventilator, which did surprise me. And they said, and then the next day they said, well, they say he's got this thing called ARDS. Not the, oh shit, he's dead. I didn't say it out loud, but that was what I thought. I mean, the minute they said to me, he's developed ARDS, and he wasn't under perfused long because I started CPR almost immediately on this kid. Now, he did not die. He actually recovered, and probably because he was a kid, probably because he was young enough, healthy enough athlete that he probably recovered because of that. He had some grave deficits, mostly because of his head injury more than anything. But he had some grave deficits, but he never skated again. But I mean, he barely walked again. But it was interesting. I mean, but the minute they said that to me, I thought, oh, this kid's dead. He's developed ARDS. He's dead. But he didn't die. But that was my thought. You develop ARDS, you're pretty much dead. But he didn't. But I forgot what your question was again. It's been a long day of talking. Did you ask me a question I didn't answer? No, I answered it. Okay, whoever asked me that question, did I answer it? But I remember well them telling me he had ARDS, and I was like, oh God, not good. This is not good. But he did live. He did live. But he wasn't in arrest long. I bet he was in arrest less than 30 seconds. Less than 30 seconds before I was there on the ice with him. So, what else? Anything else?
Would a burn patient ever go to the ICU, or would they strictly be transferred to a burn unit?
Well, it depends on where they are. I would say most will go to a burn unit if they have what's more than what's considered a minor burn. A minor burn you might keep. As if you have a good plastic surgeon that's used to doing burns, they might keep them. If they are more than a minor burn, they probably will transfer them to a burn unit. We do not have a burn unit at Carolinas Medical Center. They did when I first came here in 1981. We had a burn unit. but they closed their burn unit. And so we now have to send them to Chapel Hill or South Carolina. I know the name of it, but I can't think of it right this minute. Somewhere in South Carolina. Augusta. Augusta? No. Somewhere in South Carolina. I don't know. Somewhere in South Carolina. Those are the two closest. And we used to always send it to South Carolina, but we don't anymore. We usually go to Chapel Hill now. And a really funny reason why we always send them to South Carolina. Was it Augusta? I think it was Augusta. Because the director of the burn unit in Chapel Hill would not let us send our patients by helicopter. He believed that the change in the atmospheric pressure increased the anaerobic metabolism development in the burn patient and would cause weird bacteria in the burn patients when they were shipped by helicopter because of the change in the atmospheric pressures in the compartments and that kind of thing. So he always made his patients come by ground, but when we would send them down to South Carolina, they'd let us fly them. So we would always fly them out to South Carolina and not send them by ground up to Chapel Hill. But they got a new director and he says he has no problem with us shipping them up by air. So now we send them to Chapel Hill. So, but we used to not send them to Chapel Hill because of that reason. Now, I don't know what best practice was, but pretty much if they're more than a minor burn, they need to go to a burn center. They need where the people that go send them to the best. I don't know if you read the latest. This is just an example, and I'm not here. This might insult somebody, but I don't mean it to be insult, but it's kind of an interesting thing. You go to where the best care is. Let's just be realistic here. You go to where the best care is. If you read the latest little magazine that Atrium Health put out, it was talking about donors and people that have given money for different things lately. And George Shin, who used to own the Hornets, he doesn't own the Hornets now, but he used to own the Hornets. Donated all this money for something new in the neurosurgical area. I don't know if it's new ICU beds or new diagnostics or millions of dollars. He put millions of dollars recently into this. Well, he was at a meeting. Oh, this was, I don't know, long time ago, 20 years ago, maybe a long time ago. He owned the Hornets at the time. And the Hornets is the only sports team that goes to Presby. All the other sports teams go to Atrium Health. But the only team that goes to Navant are the Hornets. And it's for a really funny reason, if you want to know what the reason is. Atrium could not guarantee them an extra long bed. Now remember, these guys are tall. Navant promised them they would have an extra long bed in storage that they could immediately get for the players. And so they chose to go to Navant, which, hey, if I was 7 foot tall, I want an extra long bed too. So that at the time, now there may be more reasons, that may be more contractual things, but at the time, that was the reason on why they chose to go to Navant. And so when George Shin was at a meeting, he started having slurred speech and some droopiness and, obvious signs of a stroke. And so he was immediately rushed to Navant because that's where the Hornets go, is Navant. And when he was there, the neurosurgeon, and neurosurgery goes to both Navant and Atrium, well, it was Carolinas then, but Atrium Health. And they said, we're sending him over to Atrium Health or over to Carolinas because they have a neurosurgical ICU. And Navant doesn't have a neurosurgical ICU. And Navant was livid because you can imagine what it said in the news. He went to Navant and they transferred him over to Atrium Health for his care. And what does that say to the public? You have problems, don't go to Navant, go to Atrium Health. But really what they were saying, but the neurosurgeons wanted him in a neurosurgical ICU. They didn't want him in just a general ICU. And it was a real big to do at the time. But now he's giving all this money here. And he may give money to Navant too. I don't know, but he may give tons of money to Navant. I don't know. I'm not saying he doesn't, but because I don't know. But I go back to the burn unit. If you've got a burn, then send them where the expert is. And the expert is not at Atrium Health because we don't have a burn unit. The expert is at Chapel Hill. Get their butts up to Chapel Hill. Go where the expert is. Go where you're going to get the best care. And it's not atrium for burns. It's bottom line. More
I
questions?
have a quick question. I'm sorry. About the Parkland formula, will that be included in the math questions or in the burn questions on the blueprint?
It is in the burn questions,
Okay.
but you get
Thank
the
you.
time of a math problem.
Oh, perfect. Thank you.
Math problems get 3 minutes a question. And so for the Parkland formula question, you get 3 minutes for that question. So it's added in as a math question, but on the blueprint, it is included as a burn question. Does that help you?
Yes, ma'am. Thank
So
you.
really, there's 11 math problems on the test because one of them is a burn.
Okay.
So for the EKG questions, you know how they have, like, we'll have the strips and then the electrical interpretation, those won't be any kind of questions like how to care for the patient. Will it be mostly like,
Not really. I mean, I'd have to see what you mean by that, but okay, so there'll be, for 10 strips, there'll be strips. And then on all subsequent tests, there's 5, okay? But on the first one, there's 10. So there'll be a strip, and then under that strip, there'll be, and I could be making this number up. It could be 14, it could be 16, but I think it's 15. There'll be 15 choices. And it'll say normal sinus rhythm, sinus brady, sinus tach, supraventricular tach, atrial fib, atrial flutter, PACs, VTach, VFib, PVCs, asystole, first degree heart block, second degree heart block type 1, second degree heart block type 2, third degree heart block, ventricular pacer, AV pacer, atrial pacer, failure to capture. Okay, so it has all the choices, whatever number that was that I just said. I think I went through all the choices right there.
yeah.
So you look at your rhythm and you say, oh, this is second degree type 2. There's second degree type 2, and you click on it just like you would a multiple choice, but there's 15 choices, and that's what you write that. We used to have them as fill in the blank, but this isn't a spelling test. And you know what, just like when you do your math weekly EKGs, if you don't spell it right, it might count it as wrong, and we didn't want it to be counted as wrong because you couldn't spell right. So we just put 16 or 15 or 14, or whatever it is, different choices. And now you just click next to the one that is the correct answer. Now, if it's like a normal sinus rhythm with 1 PVC in it, the answer is the abnormality. It would be a PVC.
Okay. So kind of like on the homework where there's like the run, a little run.
Right. The answer would be a run of, well, in that case, it would be VTach or whatever. Yes.
Yeah.
So there's 10 of those on the first test and 5 of those on subsequent tests. Testes on subsequent tests. Okay. Then you've got some electrical considerations. And I don't know how many there are, but I have it right here. I can tell you how many there
I think
are.
there's 10.
Okay, there's 10 questions on electrical disturbances. Wow. Okay, so electrical disturbances could be other questions like, and I haven't seen the test, so I don't know exactly what's on there. But it could be things like multiple choice. It could be things like, let's do simples. A normal PR interval is A, less than 0.12 seconds, B, 0.12 to 0.20 seconds, 3, 0.03 to 0.10 seconds, 4, 0.16 to 0.34 seconds. And you would pick the correct answer. It could say you have a rhythm that is a perfectly straight line with no P waves and no QRSs. The nurse would document this as VTach, VFib, asystole, and PVCs.
Okay.
And you would say asystole. So they could describe the rhythm and you would have to say what it is. Or it could be something, it could be a select all that apply. Your patient has been interpreted to be in third degree heart block. Which of the following would be characteristics of third degree heart block?
Okay.
And you would say,
yeah.
A ventricular rate of less than 40. Yes. A P wave rate of less than 40. Don't answer that one. That's not true. It has to be between 60 and 100. You know, a QRS of greater than 0.12. Yes. You know, whatever it is. What are the characteristics of that? You would click the ones that are characteristics of it. Yes. So
it's not
select all that
too-
apply.
Yeah, so it's not too much of like getting caught up in the causes of the dysrhythmias and the care. for
I
those.
did listen to Bridget for a little while, but I didn't stay for a really long time. The causes for electrical disturbances and the treatment is not on test 1.
Okay, I didn't think she had said that, but like when I was studying, I was kind of getting caught on like what the treatment was for
Okay.
this.
However, it's on there. And when she does the code lecture on Friday,
Yeah.
now causes and treatments may fall in the code. What causes the arrest and what's the drug of choice for the arrest or for PVCs or for VFib or for VTAC, that's on the code lecture, which is on test 2.
Okay. Okay, cool.
So not all the rhythms, but the ones that she discusses on Friday, now causes and treatments are going to be there.
Okay.
Test 2. Now, with that said, in respiratory, I have talked about dysrhythmias.
Right.
And I have talked about what would you do for those dysrhythmias.
Mm-hmm.
So you might have a strip that says your patient's on the ventilator and this is happening and this is the strip you see. What would you do about it?
Oh, okay.
But it's in relation to the ventilatory content, not
the EKG.
Bridget's content. But you have to know how to read and interpret the strip in order to know what's happening with the patient to answer my question.
Yeah.
About ventilators.
Okay.
Does that make sense?
Yeah.
But that's not part of your EKG interpretation. It's not part of your electrical disturbances. It's part of your respiratory content.
Right.
Okay. I still have a test, but I know it's in the test bank. I don't know what Jane's going to pull out. I don't know.
For the EKG strips, like the ones that were on the practice math test, those make my eyes go blurry trying to see them. Are the ones on the test going to be a little bit more clear to?
Most people have absolutely no problem with the ones on the exam.
Okay. I just wanted
They're
to.
much clearer than the ones that are on the practice exams. And we know that because they're more standardized ones and not ones that actually came from patients. And the ones on the practice, a lot of them came out from a patient. But in real life, the ones that came from patients can be hard to read. But yes, very few, if any, people complain about the ones. Oh, there's always a complainer somewhere in the group. I mean, come on, let's be realistic. But typically, people do not complain about the strips on the test. And I think if you know how to do your computer, I think you could even make them bigger. I think.
Cool.
I have a question just to clarify. To determine like the calibers between like the P to P wave and R to R, we're not allowed to use a piece of paper, correct?
You cannot use a piece of paper.
Okay, so just count.
You need to hang up your whiteboard next to it. It's okay, but you can't use a piece of paper. The whiteboard, yeah.
Just to clarify. Thank you.
Cannot have a piece of paper. And you would not be allowed a piece of paper at NCLEX either. You have a whiteboard at NCLEX, but you won't be allowed a piece of paper.
Janie, this may be a really dumb question, but
Right.
I
probably have a really dumb answer.
I have like a couple of different holders on my desk that have like pens and stuff. And in Janie's email, she said that we needed to clear off our workspace. Does all of that need to go away as well, or can that stuff just sit there?
I would move it. So there's no question on what it is, if you can, if it can be moved. But make sure everything's done. Don't have any books, don't have any papers, don't have anything around there.
Right.
Or underneath your feet, don't have any papers and that kind of stuff.
So no candles.
Well, I haven't been asked candles.
I have
think
a
we
study
would-
candle.
You have a what?
I have a study candle.
I think we would know what that is. That's okay. I guess. I don't know. It's supposed to be clear. There's my answer. It's supposed to be clear. How's that for an answer? I don't know what anything would happen because of your study candle, but I
Miss
don't.
Janie, can I ask a question about compensation? I'm
Sure.
going over the ABG like worksheet, and I don't know why I'm getting hung up on question number 7.
Okay, I don't have it in front of me. Can you give it to me?
Yes, it says a client with chronic arthritis presents with the following ABGs.
Okay.
He is experiencing Kussmaul's respirations, a pH of 7.4,
All right.
PCO2 of 30, and a bicarb of 18.
Okay.
So when I was reading that, I'm like, okay, pH is normal.
First of all, what do you think's wrong with them? Before you don't skip the scenario.
Okay. So
do you think
Kussmaul's
this is
respiration,
respiratory or do you think it's metabolic?
so I was thinking respiratory because he's blowing off a lot of CO2.
Kussmaul's is always compensatory.
Okay.
That's your compensatory mechanism, just like Kussmaul's is compensatory for diabetes. So he's chronic arthritis. That's a body problem. Tell me what people take for arthritis. They take anti-inflammatory drugs. Can you tell me an anti-inflammatory drug, please?
NSAIDs?
NSAID.
Steroids.
Tell me an NSAID.
Ibuprofen.
Ibuprofen. Got another one?
Tylenol?
No, Tylenol is not anti-inflammatory. It is not. Sorry. It is not. That's why certain people can take Tylenol that can't take aspirin. Aspirin's an anti-inflammatory drug. Matter of fact, aspirin's probably the most prime anti-inflammatory drug. So your aspirin, your Tylenol, aspirin, your ibuprofen, your naproxen, your Mobic, your, I don't know, all your NSAIDs are, especially what is aspirin? Salicylic acid. Oops, what did I do? Salicylic acid. Okay. They are very acidic. So people that have chronic arthritis tend to become very acidic. So they develop metabolic, it's a body problem, acidosis. Okay. So there's 7.4. So I know this is either a normal ABG or a fully compensated ABG. I go down to my PCO2. My PCO2 is low. I already said they're in Kussmaul's, so I expected them to be low. They're blowing off their CO2. And their bicarb is low. That's what's making them acidic, is their bicarb is low. So I already said, I think they're metabolic. It's a metabolic problem. They're in metabolic acidosis. The Kussmaul's are always compensatory. That's how people start blowing it off. And so they're in metabolic acidosis that's fully compensated. Now go to the next one that has the scenario. Has almost the exact same ABGs. What does this say?
Would it be like question number 9, or are you talking about question number 8?
The one that has on the vent.
Okay, I think is a client with a cerebral hemorrhage has been on mechanical ventilation with the following setting for 4 days.
4 days on a vent. 4 days on a vent. Okay. What are they?
pH is 7.
No, what's the tidal volume? What's the setting?
Tidal volume is 700 mLs and FiO2 is 60% with a rate of 32.
A rate of 32. This person has been hyperventilating for 4 days. It's a respiratory problem. I've been hyperventilating them for 4 days. I've been blowing off their CO2 for 4 days. which is common with cerebral hemorrhages. I'm blowing off their CO2. This person is in 7.40. What's their PCO2? It's got to be low.
20.
20, and their bicarb is
12.
12. Is that what you said?
Yes, ma'am.
12. Okay. This person has a respiratory problem. Oh yeah, they had cerebral hemorrhage, but that's not a chronic problem. They have been on a vent for 4 days. They're in respiratory alkalosis. And so their PCO2 is down because I blew off their CO2, and their bicarb is down because that's the compensatory mechanism. So I got those from the scenario. I promise you, there's nothing like that. There's nothing even remotely like that on the test. I mean, the test is simple. It's simple. Simple, 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 simple. If I said to you, you got a patient and their pH is 7 point, we'll do a simple one, 36. No, that's 38, 7.38. Their PCO2 is 60 and their bicarb is 25. And I gave you 4 choices. You got respiratory acidosis, uncompensated. Respiratory acidosis, partially compensated. Metabolic acidosis, oh, wait a minute, 7.38. Wait a minute, I got to say, I'm sorry. Uncompensated and fully compensated. Metabolic acidosis, uncompensated, and metabolic acidosis, fully compensated. Oh, that's not a good choice. And fully metabolic acidosis, partially compensated. Which one is it?
Okay, so when I'm breaking down, you said it was 7.38. So that means the pH is normal. It falls within normal range. But the CO2 is high. So because the CO2 level is high, I'm thinking respiratory.
Okay.
And the bicarb is normal because it's 22 to 26.
Oh yeah, I cheated. I can't, that's a bad one. Let's make his bicarb 22, 20. Let's make his bicarb 29. I lied. 29. I got ahead of myself. 29.
Okay. So the
What is
bicarb, so the bicarb is high. Okay.
So what is it? Your pH is normal.
Right.
The other 2 are off.
Off.
It has to be
fully compensated.
It has to be fully compensated. I only gave you 1 fully compensated one up there.
Okay. So do we need, okay, so my thing is, if it's fully compensated, how do I know which one is it? How do I know?
If I don't give you a scenario, it will be something like this, that only one of those is fully compensated.
Okay.
The other 3 weren't fully, I gave you 2 uns and 1 partial and 1 fully. So it has to be the one that's fully, because it's the only one that would bring the pH back to normal. Does that make sense?
Yes, ma'am. So fully compensated means the pH is normal and both the bicarb and the CO2 is abnormal.
Right. So you really didn't have to know if it was respiratory or metabolic. All you had to recognize was that it was fully compensated.
Yes.
I really don't know what's on the test, but typically the answers are like that. They're not difficult. I mean, they're not tricky, not like the workbook is. The workbook's a little tricky to make you think, but the test is not that tricky. I mean, in this one, there's only one answer it could be because the pH is normal. And that's fully compensated. There's only one it can be. Right? It's not hard. I promise. I promise the ABGs are not hard. I promise. They're the easiest part of the test. The easiest part of the test are the ABGs. I don't know what the hardest part is, but make sure you can do your math. The math should be gimmies. The EKG should be gimmies. If you can't do your math, you should be able to do your math. It amazes me. People can't do their math. You're in 202 and you can't do your math.
I have a question in regards to burns. So I know you said within that first 24-hour period, because the capillary wall has essentially busted open, that you're not worried about the potassium levels because they're going to leak out and then come back in. Are you ever worried about symptoms coming through from giving them the LR, since LR has potassium in it?
Oh, it has not enough to do anything. No.
Okay. I just didn't know, since we're bolusing it at such a high rate with some of them, if
No.
it would be putting in too much.
It doesn't have that much K in it.
Okay.
I worry more about the lactate than I do the K. But no, I don't worry about that either.
Okay.
No. No. You could use saline just as easy as you could. They're both isotonic.
Well, that's what I was gonna ask. I didn't know if it really mattered if it was LR or saline, or if they're
Not
interchangeable
really,
as
but
far
the
as what people
Parkland
prefer.
formula recommends LR. So if you ask anybody what the Parkland formula is, they will say 4 mLs of LR times body weight, kilograms of body weight times percent burn. Everybody will say LR because that's what the Parkland formula is.
Okay.
But would it change? Would change the way the fluid shifts if you use saline? No. It's
Okay.
just everybody uses LR because that's what the standard of care is. It wouldn't make a difference.
Okay. I just want to make sure.
Make a difference. Nope. Anything else? Questions? Things just burning in your mind? No. All right. Shoot me an email. Shoot me a text. Text is better than email. Shoot me a text if you have any questions. And I think Bridge Talks teaches Friday, followed by Jane for neuro, and then I'm back Tuesday morning, I think. I only teach one lecture in neuro. I teach ICP. So we're moving on. Test 1 is almost over. It's going to fly by. Fly, 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 fly. Okay? All right, you all.
Thank you.
You're welcome. Take care.
Thanks.
No problem.